Week 4 already. Isn't that amazing? Yes, I think it's just really been going by so quickly. So you're probably used to our repertoire now. And of course, this week we're hitting domain 2, compliances with uses and disclosures of PHI. And for those of you who may not be so familiar, use and disclosure are being used in this particular case with regard to HIPAA. Compliance with use, the use of protected health information, PHI, use has to do with the use of protected health information within the same facility, whether it's doctor to nurse or billing or whatever within the same facility. When you're talking about a patient and any of their particulars, it is called use. Disclosure is releasing or sharing that information with someone who is outside of your facility. So, for example, if the physician orders the patient to, if a physician in their office orders the patient to have an MRI done, the physician's office will need to disclose the diagnosis code that provides the medical necessity for having that MRI, because you can't just go willy-nilly having $2,000 tests without a really good reason. Well, not if you want the insurance company to pay for it. Okay. So using PHI is within the facility, and disclosure is with anyone outside of the facility. And I don't mean logistically, I mean employment wise. Okay. So if you're working in a hospital and a patient's family wants to know what's happening with this patient, if you have permission and you disclose the patient's diagnosis, or you disclose what procedures that patient is having with the family, friends, family, as well as any healthcare professionals that are working in another facility. So that's use and disclosure. And remember that HIPAA is a federal law. So no matter where you are, no matter the size of the facility, you and everyone who works there must comply with HIPAA. Also remember that everyone who works there includes volunteers, full-time, part-time. It doesn't matter if they have any opportunity to see, observe, read, or hear protected health information. That is part of the covered entity, and they must comply. One step further are any contracted services that might have people who work for other companies that might have exposure to your patient's PHI. And that might be a company that is contracted with to come in and take care of your computers, okay, an IT company. It might be a separate outside billing, coding and billing company, okay. In those cases, they do not come under the umbrella of the covered entity. So therefore, you, and I mean you, the health information management or health informatics director, you are required to ensure that the contract with this outside company includes the business associate clause, which basically contractually obligates this company to protect the health information of any patients which it may have access to. Okay? And that right there in a nutshell is 26% of the entire RHIA test. Okay? So this week you're going to do a domain 2 practice exam. From what I saw, most of you did very well on domain 1. So you should be feeling pretty good about yourselves. Remember, 75% or higher is passing. That's only a C. You guys can do better than that.
Did you mean passing on the exam itself?
Mm-hmm. The RHIA.
Okay, you just need 75% and
75%. That's
okay.
right.
Okay.
The entire test is worth 400 points, and you have to get a score of 300 or higher to pass.
Question about the codes. How do they do it on the exam? Because even doing your exam is a little tricky with
Yes,
the code.
and
Are they going to give you like a list of codes for you to just work out? Some were easy, but some were a little tricky.
Yes, they will do exactly that. You will not have any links or anything like that. They will include in the area with the question, they will give you all of the possible codes presented in the multiple choice, and they will give you their descriptions. So you will have that information from which to choose the correct answer. So you still have to use your critical analysis skills, but you don't have to go anywhere, and you don't have to deal with any code books. It's just that particular segment of information will be included on the question.
Which means you will have to know then what the disease is, or you'll just have to know, right?
That will be in the question itself.
Okay.
So in other words, let's see. They'll ask you a question like, the patient is admitted with pneumonia and is in the hospital for 3 days and is receiving respiratory therapy. Okay, here's one. A full-term newborn vaginal delivery born in the hospital. The birth is complicated by cord compression, which affected the newborn. And then they will give you the 4 or 5 or 6 codes that they're going to include in the multiple choice answers with their definitions. And then you choose the answer that matches. Remember, the entire RHIA exam is multiple choice.
Right. Okay.
Okay. Does that help?
It does. It does. Thank you.
Good. You're welcome. Yes, and I want to, I don't know if I'm supposed to do this, but I'm going to do it anyway. I apologize. They were supposed to fix that in the exam. I don't have control to fix it. They were supposed to fix it and get rid of those links. But evidently they didn't, because I did get quite a number of emails asking about them. So should it come up in a future section? I don't know that it will, because usually coding is focused on one domain. But if it comes up, open up a separate tab on your computer and use Google. Enter the code that you're trying to figure out what, get the definition for the code, and then space, a plus sign, space, and then the kind of code it is. So it'll be CPT code or ICD-10 CM code. and Google will tell you what the definition is.
So now you tell us, because I nearly got messed up on the exam, because when I clicked on it, I couldn't get out of it. And once I clicked the X, I almost lost the page.
Oh, I'm glad you didn't. Okay, if that should happen again, excuse me, if that should happen again, contact technical support. Remember, technical support is there 24/7 for you.
Right.
And tell them that the exam actually instructed you to use this link. You did, and you got kicked out of the test, and they should be able to let you back in. Okay. If not, email me, and the next day I'll let you back in. Okay. All right. And you know, this is one of those things where in big organizations, when they have segmented authority and ability, okay, I have the skills and the knowledge as to how to correct it, but I don't have the authority, because University of Maryland, and this is understandable, University of Maryland, instead of letting each instructor create their course based on the syllabus, they create the courses. One person creates the course, and then it's duplicated and provided to any instructor who's assigned to teach it. So this course is already done. They don't provide me with academic freedom where I can't give you extra stuff, but I can't change or adjust anything that's already there. Okay, which is why I continually encourage you to email me and talk to me if you feel that you need more information or you don't understand anything, because I can provide extra to you. Okay, so that's the way it is, and we all learn to live with it. Now they do that just so that you can understand. I mean, you're a master's degree student, so you should understand. They do that for continuity of education. This way, every single student is getting the same exact course, the same exact information per se. Okay. And this way they can guarantee, as for example, you are enrolled automatically in a course, and for some reason you don't like your instructor or something happens, you want to change in the middle of the term to a different section, you can do that without any negative impact on your education or your grade. Okay, so there you have it. There are other schools that allow what they call academic freedom. So in other words, they would say, okay, here's the syllabus. The syllabus contains the minimum that you're going to give the students. You decide how you're going to give it to your students, in what format, you know, and things like that. And then I decide, you know, what might be a video or what might be a quiz or what might be an essay or something like that. But that's not University of Maryland, and I respect that. Okay, it's really two different perspectives in how to best provide you with a quality of education. Okay, you saw that. Okay, good. All right, so domain 2 is, as I said, compliance with uses and disclosures of PHI. And remember what I said, and I need to say this to all of you and those who are listening tomorrow to the recording, but please pay attention to me. For the domains, each week you're going to have the same essential discussion forum. You're going to go find an article that matches one of the tasks, and you're going to write about it in the discussion post. Okay. What I saw for domain 1, and today begins domain 2, is pretty much the same that I see every semester that I teach this course. And please, please, please do yourself a favor. Find an article that has information you can use and get that out of the article. You're just not, this isn't the 5th grade where you're writing a book report. And that's what I have been seeing from some of you is I'm getting, I couldn't read the whole book, so I just read the flap. And so here's the summary of the article, and here's the words that match into the domain, and thank you very much. Okay. Yes, that's fine. And yes, that's going to get you the grade. But you know what? It's not going to get you the knowledge that you need to pass the test. Either one of the tests. Because remember, this stuff also is going to show up on the CPHIMS or the CAHIMS. Okay. So you can just chew gum, but you're not going to get any nutrition. I want you to eat something nutritious. I want this not to be just a, yeah, I'm doing the task and it's over with. I want you to actually learn something. Okay. So there I said it. And just like I said last week, I want you to pay attention to the verbs in these tasks. Manage, apply knowledge, because that's what I'm talking about. Okay, I'm talking about how you will use this information when you are on the job. I don't want you to just do this to get the discussion grade. Because I don't know, that just seems like not the most beneficial way to spend your time. Well, I know for a fact it's not the most beneficial way to spend your time. Okay, manage patient access to their health information. This means that you have to be able to understand how the patient portal works, understand patients. When they say patients have access to their health information, they are not allowed into the EHR. The patient portal is a separate thing that, yes, is connected, but you have your hand on the handle as to what is permitted to go into the patient portal and what is not. Also, remember, HIPAA says patients are allowed access to their health information when they request it or through the patient portal, except psychiatric notes. And trust me when I tell you, it's the exceptions to the rules that are going to be on the test, right? Because that's the most fun part to write about. Okay. All right. So that's what that is about. Apply knowledge necessary to advocate for patients and families in the process of obtaining health information. So that to me says, helping patients and their families understand HIPAA rules and regulations, and most importantly, understanding the release of information form that must be completed and signed by the patient or the patient's guardian or surrogate. Okay. Apply knowledge necessary to process healthcare information requests according to regulatory standards. Okay, so this is going to have to do with the parts of HIPAA's privacy rule that give you permission under the physician's best judgment, the facility's best judgment, the HIM director's best judgment. This has to do with complying with subpoenas, dues, take-ums. When do you need patient permission? When do you need patient permission and when you don't comply. I would also include complying with police requests for information, because that also is permitted by HIPAA's privacy rule without patient information if it's for the good of the community. Okay. All right. Monitor access to PHI within the organization. This has to do with access control. Not only access control, but making sure that someone, now remember, your job as a manager or director does not mean you have to do these things. You have to make sure they get done and get done accurately. Okay. So this means making certain that not only are passwords and usernames processed properly with the appropriate permissions, okay? In other words, coders and billers need access to the patient record, but they only need access to read. They're not legally permitted to enter anything into the patient record. So they would get read-only permission, whereas a physician or a nurse or a radiologist is going to need both read and write permission. See the difference? Also, checking the records to find out if people who shouldn't be looking at patient records are looking at patient records. One of the best examples in real life that we have of that, it happened many years ago, but it's still a really good example. George Clooney, you know, the handsome one, and still handsome after all these years. But okay, George Clooney, many years ago, before he was married and a father, was in New Jersey riding a motorcycle with his girlfriend. They got into an accident. They were taken to Passaic Hospital and treated in the emergency room. What happened in the following days is, because the HIM director was doing their job, they discovered 22 staff members of the hospital, nurses, physician's aides, as physician's assistants, were peeking in at old George's medical record, even though they weren't supposed to. You know what happened? Anybody know what happened? Yes. Well, some of them got put on suspension without pay, and a bunch of them got fired. Very good. That is correct. And so the fact is that is the job of the HIM director. Again, you don't necessarily have to check those reports every day or once a week or whatever, but you have to make sure somebody is checking them and that consequences are, what's the word? Yes, enforced. Thank you very much. You know, I can't hear you, but I can read your lips. This is very excellent. I love it. Thank you. Okay. All right, number 5, apply knowledge necessary to comply with retention and destruction policies for healthcare information. I am sure I had a question about this when I sat for my RHIA. Is, you know, you can't just take medical records and throw them in the garbage. Why? Because there are dumpster divers all over the place. All right. And I think somebody mentioned this in a discussion post that, you know, medical identity theft is worth more on the dark net than social security numbers. Okay, so you have to understand what the retention and destruction policies are. Yes, it is true. You are only dealing with electronic health records now. You may have some paper, but the point is you have to understand about the dating and timing and the signatures required when destruction is done. You must have witnesses to the destruction. You must know how many years you must keep a patient's record after this patient has not been seen in this facility. Okay. For pediatric patients, it's 5 years after the age of majority, which would be age 23. For adults, it gets complicated. It gets complicated because there are no federal standards and each state is different. It could be 5 years, it could be 7 years, it could be 10 years. A HEMA, I believe, is, Brian, do you remember? 10 years? 7 years?
7, I think.
7.
I
Okay.
think 7, or at least that's the number that always sticks in my head.
There you go. Okay. So it can be a challenging question to ask. See what Oates Water says. Okay. All right. Apply knowledge necessary to monitor release of information workflows. So before we were talking about understanding what is necessary to legally disclose information, release information to other people. That's another thing that has really been a godsend about patient portals is you qualify the patient, you give them a username, they create their own password. Nobody else knows that, including you. So they can get their information without you having to have a whole ROI department, but yet still we have them because there are a lot of patients who, shun patient portals. Okay. So you have to understand the workflow. In other words, how are you going to make sure the patients have access to the form? Make sure that they are taken, authenticated, and then if there's paper, copies are made, which can be charged for $1 a page. And then how is that going to be provided to the patient? The patient going to come pick it up? Are you going to send it by certified mail? How? Remember, you can't just dump that in the regular mail either. Okay, so we're talking about the processes. All right. Breach of information protocols. Oh boy. You need to check this out. It's really pretty systematic. However, there are lots of layers to breach of information protocols, depending upon how many patients were affected. It will range in anywhere from you notifying those 10 patients that their records were potentially breached, all the way up to more than 500 patients where you not only have to do that, you have to notify the press. Yes, that's where those stories come from that you see in the news about a hospital having, patients' information breached. Is they're required by federal law to do this. And then there is also the requirement for notifying the Secretary of the Department of Health and Human Services. Okay. For any of this, if you cannot find the information in your Oates and Waters book, please email me and I will give you a link to the website where you can read this for yourself. Okay. Again, this is going to be a little bit memorization and a little bit understanding of the protocol, but of course we take this very seriously. All right, and last, apply knowledge necessary to ensure compliance with privacy initiatives. These are the policies and procedures that you create. Oh no, you guys have to create the policies and the procedures, and then you have to do the training, and you got to make sure that everybody complies with this. Now, when I teach HIPAA's privacy rule to non-HIM professionals, I can do it in one sentence. Okay. And that is keep your big fat mouth shut. Don't be talking about other people's business to other people whose business it is not about their business. Okay. Then there's the asterisk. And there's the secret that I will tell you, which is human nature being the way it is. You're working going through a patient record, and you see that a patient came into the ER with pieces, all the little tokens from a Monopoly game shoved up their butt. I saw that on a Law and Order once. Okay. But the fact is you can't read something like that and not tell people. But still, you must protect privacy. So we do not use names because the names don't matter. The whole story is what this person had up their butt. Okay, so you leave out the names, change the gender. If they're from Baltimore, tell them they're from Myrtle Beach. I know that that's South Carolina, but that's exactly my point. Okay. All right. But you also have to remember that because it is your responsibility not only to write the policies and procedures, but to train everyone. Okay. Volunteers, full-time staff, part-time staff, everyone. Okay. You have to remember that the training, which has to happen upon hire plus annually thereafter. Okay. You have to remember that your training must be geared toward that group's, your audience's interaction and responsibilities with patient information. Okay. What that means is you're going to have a different training session for the nurses than you are for the environmental, what are they called? Environmental, help me.
Environmental services.
Yes, environmental services. That's right. That was a hard word, Shelley. Okay. Environmental services, we used to call them housekeeping. We don't call them that anymore. They're now environmental services. And they work very hard.
Yes.
Right?
You could just say EVS as we call them at work.
EVS, environmental, oh, right. I got it. Okay. EVS. Okay. It sounds like it sounds like, no, I'm not going to say it. Okay. Anyway, so that's your job. You have to know that you have to change the training to suit how that particular job group interacts with information. So when you are training EVS, okay, you're going to say to them, you may overhear talking, or you may, glance at a screen and see information, and you have to make sure you don't look at it. Whereas nurses and doctors can actually log into the computer, and then you tell them the story about George Clooney. And if you have a lot of women, you want to show them a picture of George Clooney, and that will get their attention. Although they may not be thinking about privacy at the time, but you know what I'm saying. Okay. Number 9, ensure compliance with security initiatives. Okay. So, a lot of times, so many people focus so hard on teaching about HIPAA's privacy rule that they forget about HIPAA's security rule. I'm going to make it easy for you and tell you that the safeguards, administrative safeguards, physical safeguards, and technical safeguards, very specific, laid out in the security rule. That's what you need to know. You don't need to know most of the rest of it, okay? But you do have to understand about role-based access. You have to understand about firewalls and biometrics, and I'm amazed that we don't talk more about it. Maybe it's too expensive to do, but if well, now it's, if you have an old iPhone, no, even a new iPhone, the computers where you could use your fingerprint to open the computer or unlock the computer or the phone. And now it's Face ID, which is really funny because if I'm outside, I already got vaccinated, but if you're outside and I have a mask on, my phone doesn't recognize my face. But anyway, my point is that's what you need to study for this part. You need to understand administrative safeguards, technical safeguards, and physical safeguards as identified and regulated under the HIPAA security rule. And again, this is pretty straightforward and it makes a lot of sense. Okay. Physical access, make sure you put a lock on the door to the offices that have computers that are capable of accessing patient records. I mean, that's very logical, right? Okay, so you can do this. And last but not least, in domain 2, monitor organizational compliance with health laws, regulations, or standards. And that's your big old everything in a basket. This, I think, would best suit you to review the standards for compliance plans. We forget, but that's also our responsibility. And as of many years ago now, physicians' offices and physician groups, as well as hospitals, are, well, I think hospitals are required to have a compliance plan. Physicians' offices are strongly recommended to have compliance plans. It's just really a good idea. And there is, of course, great information about this. And again, if you can't find it, email me. I am happy to share. Okay. Again, they're not going to ask you to write a compliance plan in the exam because that would be challenging. But you have to become familiar with your responsibilities with regard to compliance plans and the various and different laws. Don't forget HIPAA. Yes, we all know HIPAA privacy rule, HIPAA security rule, but you also have the Federal False Claims Act. You have EMTALA. Okay. So again, look in your Oates Waters book. I think they have a good overview of all the different laws. Get a feel for them, understand them, and then just say compliance. That just means not violating federal law. What a good idea. And the good news is, because this is a national certification exam, there will be no particulars about whatever's going on in whichever state you live. So you don't have to worry about when the state doesn't agree with the federal law. But you do need to know that if HIPAA says you may, and a state law says you must, then you must. The state law over whichever is more directive, okay? If HIPAA says you can't, then you can't no matter what. But, and this particularly goes with, and this comes up, this particularly goes with reports to the state health department. For example, if any patients are diagnosed with, let's say, a contagious disease, like COVID, most state law and most state laws have a nice long list of mandatory reports. Okay, infectious disease, sexually transmitted diseases. You know, there's a whole bunch of stuff. And so you just need to know that when state law says you are required to report to the state, HIPAA for the most part will say you may, if you find it, you know, to be. So it is a permitted use in your judgment. So I'm pretty sure your judgment will be, I don't want to go to jail. Yeah. Okay. If you have a question about whether or not you want to go to jail or prison, again, I only know about these things from television, but I'm pretty sure you don't want to do that. Okay. Also, here are links 2, a summary of a HIPAA privacy rule. Really good summary because it's only 6 pages long and it really lays out everything very neatly. If you're worried about copying down these links, first of all, I will post this, but second of all, this is much easier. Go to Google, type in HIPAA privacy rule summary. Boom, it'll come up. Okay, I recommend you downloading it. 6 pages, Word document. Okay, I think it might be a PDF, but whatever. The point is, and then the summary of the HIPAA security rule, same thing. That's gonna take you to a page. They don't have it as neat and tidy as the privacy rule, but you can just copy and paste a section out, or again, ask me, I'll be happy to help. But these are really great study tools. I mean, you're talking about just condensing all the important parts into a couple of pages. It's not as overwhelming as it might seem on the face of it. Okay, any questions so far? Okie dokie. All right, Capstone Project Step 2. I know I haven't graded Step 1 yet. It's on my to-do list. I apologize. I know you don't like waiting for your grades. I always hated waiting for my grades. I will get to it. But in the meantime, you get to work on Step 2. Okay. Highlight changes from, that should say from, not form. Oops. From current to future state. So in other words, you want to spell out what's actually changing with regard to who has to do what. In many cases, when transitioning from paper to plastic, oh yeah, so you're still not laughing at that joke. It's okay. It's okay. All of my jokes are gems. Some of them are star sapphires, others cubic zirconia. I inherited my father's sense of humor. May he rest in peace. Okay. A lot of times the changes will be very simple. So in other words, use this tablet or the computer in the patient's room or the computer at the nurse's station to enter your documentation instead of grabbing this form, you know, from this drawer, which isn't, and then also they don't have to put the form anywhere. So it does make it a lot easier. How the paper-based medical record is stored and consulted, in other words, one person at a time, only in physical proximity to it, versus the EHR, which means not only can you access a patient's record from any computer in the hospital with your password, username and password, but, and we're in 2021, you know, physicians are going to have encrypted, very important, encrypted phones and tablets and laptops. So when they are not on the premises of the hospital, they can still access the patient's record. This is very handy. Some of you can remember in healthcare before, you know, if a patient needed pain meds, the nurse would, and the doctor was not at the hospital, the nurse would have to page the doctor, call him on the phone. Then there were procedures with taking, you know, physician orders over the phone. First of all, most of the time that you have to wait for the doctor to call you back because for whatever reason they never answer their phone. Okay, then the doctor calls you back. And the doctor calls the nurse back and gives the order. Then the nurse must write it down and read it back to the physician to make sure that she or he wrote it down properly and correctly. Then the order for the medication must be sent down to the pharmacy so the pharmacy can fill it and bring the medication up so the nurse can administer. Oy, that's exhausting. Now, the nurse sends a text message to the physician. The physician will open the patient record, open the CPOE on an encrypted device, mobile device, and enter the order directly, and that will directly go to the pharmacy. And 5 minutes later, all right, maybe 15 minutes later, the medication is up at the nurse's station waiting to be administered. Okay, it saves a lot of time. More importantly, it is more accurate. And CPOE, computerized physician order entry, has saved thousands and thousands of lives, 50,000 lives the very first year CPOE was implemented in the United States, which is 50,000 lives saved. Unbelievable. Okay.
So the exhausted example that you displayed first still happen. Not as frequent, but it still happen because there's an option in the EMR with readback. Because if the provider does not have access or just somewhere where they don't have access, you have to do a telephone call and you have to put in the order as a readback and you have to do all that. And then when they come back to the hospital or healthcare facility, then they have to sign it.
Right.
So,
you are exactly right. And as we live in this digital age, I think we're all aware of the old-fashioned backups. I mean, not only computer backups, but the old-fashioned backups where you have to do it the old-fashioned manual way, because things happen. And we can't, and it's interesting because we can't forget that. You know, lightning can hit a hospital and knock out their electricity. Or the computers can go down. A hurricane can come. I mean, these things happen. And I know all of us are so used to our electronic everything. How many of you have an actual old-fashioned deck of cards somewhere in your house? I do too, right? And you won't get rid of them because just in case, okay? So the point is you are absolutely right. We have to have that training. We have to have somebody who knows how to do that, or at least put it in the emergency manual. And you know, it's so easy to say, well, the emergency manual is right on the computer. It's right there. You see the icon, and it goes, no, no. You need an old-fashioned 3-ring binder, because if we have no electricity and the backup generators aren't working, then the fact that it's in the computer isn't helping anybody. Okay, so yeah, we have to straddle, but just a little bit in the old world, and that's probably something else that should be put on your list, you know, it as a whole on this changeover from particularly from paper to digital, but even so, to make sure that there are backup generators for the facility. Now, I can't imagine an acute care hospital or even long-term, short-term rehab nursing home that doesn't have backup generators, but you might have a physicians group that does not have a backup generator. And living in Florida, and we just started, I don't know if you know, but June 1st is the beginning of hurricane season. Yay. Which means they're constantly on the news, constantly talking about hurricane preparedness, which is good and it's right and absolutely. But the fact is that, so of course, all of the, you know, like Home Depot and Ace Hardware are all advertising home backup generators. But okay, so my house is not the size of a hospital, but it still could be close, or well, it's not that, but you know, for a backup generator is $400 or $500 is certainly worth the investment to a physician's office or a physician's group to have on site. it might just be worth the investigation and the discussion. Okay, depending upon where you are. Now, if you're living in Kansas, you don't need it because of hurricanes, but you would need it because of tornadoes. So there you go. And what, in California? Yes, exactly. Earthquakes. Earthquakes. Okay. These are just some examples of things to consider when you're looking at workflows, how patients are scheduled, how they are checked in, how are their records pulled, if you will. Okay. And, I would also maybe consider telemedicine. Thanks to COVID, telemedicine has become a part of our delivery of healthcare services. And from what I am seeing, it's not going to go away, which I think is a good thing. So you might want to start incorporating that in workflows as well. But assigning patients rooms, now you might think, well, that has to do with a hospital, but no, when you are in an outpatient facility, you still have to put them in an exam room. And you know what? Only one patient per exam room. You can't have them share that little exam table unless they're familiar with each other. Don't go there. Okay. All right. Renewing medications. By this time, honestly, if they're not doing renewing medications through the patient portal, then you need to teach them how to do the patient portal. Messages. Oh, you know what? My doctor's office just got their very own app. So now I don't even have to go to the patient portal. My patient portal comes to me. It's a me. And then they send me text messages. So all of these things, and really, truly, we have discussed this before, but this whole paper to digital is not something you will have to use readily as you are out there in the real world, because as we have discussed, we are in the over the 90th percentile with everybody already digital. So for you to actually be working for a healthcare provider who's still using paper records is going to be few and far between. So I can't change this whole assignment, because there are still good things you can learn, critical thinking, but I do want you to incorporate new technology, okay? Not patient portals anymore, but an app, sending messages via encrypted text messages, okay? Renewing medication, CPOE, which is send prescription to pharmacies electronically, and that now in the past few years has expanded to sending orders to imaging. It's not just in the same building, it's even outpatient services, and also lab reports. I mean, lab testing. The physician writes an order, enters it in CPOE in the exam room with the patient there, and boom, it's at Quest Labs, or it's at the imaging center, or it's at the pharmacy, whatever is appropriate. But my point is this works, and this is current reality, both in outpatient as well as inpatient, where everything is in the same building. Okay. And keeping track of health information entry timestamps, that's the computer is doing that. You just have to make sure the computer knows what day it is and what time it is. And you know what? Most of the time, my computer knows that information better than I do. Oh, it's Wednesday? Oh, okay. All right. You know what I mean, right? Okay, so these are places where you can really do your research and learn about what is happening out there right now, so that when you are on the job and when you are in an interview, whether it's for a promotion or a new job, if you start talking about things that are no longer generally done in the industry, they're going to say, thank you very much. We'll let you know when we make a decision. And they will never tell you it's because your information is outdated. And this is exactly why I am such a pain in the gluteus maximus about the currency of your references. Technology, no older than 2018. General information, no older than 2017, 16, 17. But you know what? There's information being published every single day. I want you to be reading those articles that were published this morning or yesterday, not 3 years ago. And they're there. And again, if you need help finding them, I'm happy to help you. But I don't want you getting out there and have somebody say, what are they teaching you at that school? When did you get your degree? 18 what? 1857. The year I was born. Okay. There's a note on your capstone project. The only reason I put this here is to give you kind of a, I don't know that any of you can actually do this because, you know, hospitals and doctors' offices, for the most part, have implemented EHR at least since 2017. I don't know if you could actually remember back so far where your doctor was using paper and now comparing it to now. I didn't write this. I think if you think about maybe last year versus this year, or just look at the new innovations and understand that new things are coming out every minute of every day. Speaking of which, did you all hear that for the first time in quite a long time, the FDA has approved a new Alzheimer's disease drug? Isn't that fantastic? Unbelievable. This is big, huge news. And we knew about it 10.5 seconds after it happened. That's the information I want you to, what, no, 10.5, 9.5, 5.5, 2.5. The point is, as you know, the point is that it was approved in the morning. I think by the time I sat down in the evening to read the news, I was right. I already know about it. Stop telling me about the new Alzheimer's drug. I know about it. It's just like within 10 hours, I had already heard about it so much. I'm like, okay, all right. But this is fascinating. And this is a perfect example of if you're looking at something that was written a year ago, there's not going to be anything about this Alzheimer's drug. I don't want you to have old news. Okay. And especially because I don't want them saying, what did you learn in that school? And who was your teacher? Yikes. Say, my professor was this pain in the gluteus maximus who kept saying, I want you to know what's going to happen tomorrow. I don't care what happened yesterday. Well, maybe yesterday is okay. All right. Questions, comments, suggestions, recipes. It's dinner time. All right, I'll go get my own dinner. Have a wonderful evening. And please email me if I can help you make this course better for you. Okay? All right.
So
have a good night.
Are we going to get our paper before Saturday? The grade?
Yes, I will give them to you before Saturday is good. Yes. Yes. I promise I will grade them before Saturday.
Thank you.
I was a Girl Scout, so this is kosher. Although 3 fingers, 2 fingers, I don't remember. Brian, were you a Boy Scout? No. Okay. I promise by Saturday evening, just to cover my butt, but I'm going to do it sooner than that. Okay.
Thank you.
And this is being recorded, so I can't deny I said it. However, I can say, I'm so sorry you misunderstood. I didn't say which Saturday. Specificity is so important. Have a good evening.
Thank
Thanks
you.
for
Professor,
joining.
thank you.
Bye.
Bye.